Welcome back to another episode of the Brawn Body Health and Fitness Podcast. Joining me today is Dr. Justin Tallard. Justin is a previous podcast guest and one of my go-tos for all things relating to shoulder, elbow, general arm type injuries, especially in overhead athletes. And today, him and I are going to be discussing exercise prescription for overhead athletes. So in particular, where do things like perturbations fit in? Is 3 sets of 10 IR/ER enough? How do you go about programming your rehab for your overhead athletes? So great episode, a lot of great little takeaways and points in this one. I know you're going to love it. Before we get to it, though, be sure to check out our Season 5 sponsor, Isophit. They're my go-to for all things isometric strength training. Enjoy. Justin, welcome back to the podcast. Super excited to work with you again today, man. Thanks for being here.
Absolutely. Really appreciate you bringing me back on. So excited to get into the weeds here.
I only bring people back on if they're good, Justin. So, but maybe people didn't hear you on our last episode where we kind of talked about a lot of different things relating to baseball. If they didn't hear that, would you mind filling them in a little bit about who you are and all the amazing things you're doing?
Yeah. So I'm Justin Tallard. I'm the current rehab coordinator for the Philadelphia Phillies. I've been here since 2022. So this will be my third season coming up next year. Prior to that, I completed a sports physical therapy residency at Houston Methodist, where I worked with like Rice University, the Houston Astros, the Houston Dynamo and Dash, the Houston Ballet, basically all the Houston sports teams. So I was really fortunate to have some great mentors there. Prior to that, I got my physical therapy degree from UTEP, and before that, I was in Iowa, studying sports science and Spanish at Loras College.
That's awesome. That's quite a backstory. It sounds like you've kind of jumped all over the map there, Justin.
Yeah, it's I'm actually in Wisconsin right now for the off season. It's snowing, a little cold, and I moved south for physical therapy school to get away from the cold, and now it's ironic that I've got all this off time and spending it in the cold.
Yeah, seriously, man, you're missing that Florida sunshine, I'm sure. And, it's funny because I feel like Florida is one of like the two meccas for baseball. I feel like a lot of the baseball guys I know are down in Florida there. And when I think baseball, I feel like it's just a very rotationally dominant sport in nature. It's high force. There's a lot of repeated motions. You guys play such a long season in general. I feel like that probably sets you up for a pretty unique round of PT considerations on what you would see in a baseball athlete. What do you think?
Yeah, I mean, absolutely. I think baseball is a pretty unique sport, and really just has some really like specific demands, just like any other sport. But baseball, especially like you said, like we're a unilateral sport. Most guys only throw with one hand. Obviously, they bat from one side. They're doing everything the same in the same motion over and over again. It's really repetitive. And as you mentioned, it's 162 games. Takes a lot to be able to do the exact same motion over and over and over again. And obviously, on the physical therapy side, we see, a lot of results of that repetitiveness end up causing problems or being issues at some point.
Definitely. I was having a conversation with someone earlier today, and we were talking a lot about the shoulder and the elbow in baseball. And this other individual, he made the comment, he's like, look, for a lot of these guys, it's not a matter of if, it's a matter of when things start to break down. When we start to see some rotator cuff degeneration and labrum irritation and that sort of thing, like, he kind of proposed like, hey, it's going to happen. It's inevitable with the amount of volume that some of these guys are putting in. But I feel like a lot of people jump right to the shoulder and elbow. Do you ever see anything other than shoulder and elbow in such a throwing rotational dominant sport?
Yeah, I mean, the list kind of goes on, and I think I'm always sometimes surprised by what we end up seeing, and the issues that some of our athletes have, because it's not just shoulder and elbows, even though that's probably 80 to 90% of it. And obviously, like most of that is pitchers. Kind of, you just reminded me of this like stat blurb that I read on LinkedIn at some point over the year that was like 80% of, like baseball pitchers at some point have some kind of arm injury over the course of their career. So like, obviously that's what we deal with the most. But to your question, like we see things from people's toes to their heads. And there's obviously some really like commonalities within that, right? Like one thing that a lot of people don't think of is concussions with catchers. So like there's a big, obviously if you miss catching 100-mile-an-hour pitch and it hits you in the face, you might be a little bit concussed. So that's a pretty big issue that we see sometimes. Other things that we actually see a lot of that I like continue to try to learn and grow with. So especially with hitters, like there's hamate fractures, there's TFCC injuries, there's like hit by pitches where you break a finger. So there's a ton of hand like manual therapy techniques and just like exercise specific things that we could learn a lot from like our occupational therapist counterparts and certified hand therapists. And then obviously like we see a ton of like lower extremity injuries as well. I'm not to the same extent of those shoulders and elbows, but there's ACL injuries that happen. There's hamstring injuries are huge. There's foot and ankle injuries and all of that happen, and we have to be able to deal with.
I'd imagine that makes for some interesting, injury mechanism type stories there. Like, when I hear the concept of hand fracture, like you mentioned there, my mind doesn't first jump to like baseball or really sports. So it's just kind of interesting to hear, like, you kind of explain like, yeah, if a guy gets hit by 100-mile-an-hour baseball, like, something's going to give. So it's interesting to kind of hear that kind of breakdown, because that's not where my mind initially goes, where I think baseball. And, the other thing I've heard time and time again, there seems to be a very big obsession lately with, disassociation of movement at the lumbopelvic hip complex. Can you isolate this movement versus that movement? How well can we isolate shoulder movement while the hips stay stable and vice versa? And I found a lot of times the work that gets done on that typically goes along with some kind of like hip pain or back pain or something along those lines as well, from at least what I see in an outpatient clinic.
Yeah, absolutely. I think, like there's a huge like impact of the entire kinetic chain on the throwing and hitting motion. So like hip range of motion deficits or just hip issues in general pop up. A lot of the times those don't end up being like long-term things that come hang out with me, but they're shorter term things that our athletic trainers and strength coaches do a really great job of like managing across the season. But definitely like a huge like impact in baseball, and if we could get really deep in the weeds on like the importance of the kinetic chain and starting with your toe all the way up to your arm, and how that's going to make a huge difference in your performance and your health. If you're having, limited hip rotation, you're not able to really like stabilize or disassociate, like you mentioned.
You mean to tell me not every rehab is a long-term rehab, Justin? You mean some people just get better in like a week?
Hey, thankfully it saves me some work, and thankfully I work with some really great people, so they save me a lot of work on a daily basis.
Yeah, no, that's great. And that's the kind of thing I think at the end of the day is sometimes, athletes are feeling something, and a little bit of pain control or a little bit of range work or something like that can really go a long way, right? Like I think, looking at the AT field in particular, I feel like the AT field tends to get a lot of those acute type things. And sometimes there's value in those little modalities and manual things and all those little things that, I know some people like to throw shade at, but if it gets people feeling better and it keeps them in the game and we can do it in a matter of a couple days, I'm all for it. But there's times when, as we mentioned, people sometimes need longer term rehab. And I feel like a lot of people do really well at phase 1, phase 2, get the pain controlled, start getting things moving again a little bit. We don't have to be too, fancy or elaborate there, but I feel like once you get beyond the phase 1, phase 2 rehab, once you start to get into like the strengthening part of a rehab program, that's where I think, at least from my experience looking at other PTs, I think that's where people start to kind of get lost. That's where people start going off into every which direction there. Do you tend to see something similar, or?
To your point, like the restoration of, like range of motion and strength and like managing pain are all kind of like relatively simple from like hey, let's make this stop really like hurting acutely, but then to be able to like apply that to say we have the goal of like not only returning you to your previous level, but to a better level than previously, or to be better than you used to be when you go back immediately. Like that's really like the challenge. And that's where I think like you're saying, end goal that I just mentioned, having that from the get-go and in those early phases really makes those later phases easier. So if you can like blend those things together and make it a little less like, okay, we're just focused on, I'm just going to get your elbow moving normally right now. And you can mix that in with a little bit of, like what baseball specific or like deeper level goal specific things do you need to work on, and how can I mix those in? So one, you're probably a little bit more engaged in the rehab process, and two, like you have an opportunity to like work on what you're going to end up working on in those later stages anyway. From an early standpoint is really important in my mind.
You've got the end goal of the athlete needs to play baseball, so we're going to try and make sure they're good at baseball. To use the line from Eastbound and Down, Kenny Powers, everyone's favorite baseball player, right? Like we're not trying to be the best at exercising here. We play real sports. So if you can, get full elbow extension after UCL, like that is essential. That is important. That's great. We need to do that. But if we could do that and hit like 2 or 3 other things at the same time, then hey, we might as well do that.
Yeah, absolutely. And then I think I'm also saying like each individual athlete has like specific things that they're working on to be a better baseball player, whether
Right.
they're, like at the peak of their game or just starting out their career. Like, so the earlier we can identify those things and incorporate them into what they're doing, like the better job we're going to do as a whole, and the better our medical staff is going to be, and the better our, like organization is ultimately going to be.
No, definitely. I think that's a great point. And kind of taking it a step further here too for a second, I feel like a lot of PTs always focus on the injured side, right? So, if you've got a right-handed baseball player and they injure their right shoulder, then we're going to do all the work on the right side. But I'd imagine you could probably find ways to train the left arm too while they're recovering on the right side. And I would think that training the left arm might actually offer some benefit to the right arm too.
Yeah, absolutely. Obviously, like there's crossover effect that happens. But I think like just knowing your athlete, and we obviously strive to like know every player in our organization to be able to, like help them be the best baseball player they can be. So like being able to identify those goals, even for non-hurt people, can be difficult. But like, I think sometimes we as physical therapists don't recognize the impact that we can have, not only on, like health, but on performance as well. And the more we can like obviously sell that and talk about that, like nobody outside of when somebody's hurt, nobody really cares about, like all the little things that they do to get healthy. They more so care about, like being able to perform at the highest level that they can.
As we were kind of mentioning there, it's pretty essential that, we focus in on the demands of baseball. And as we mentioned thus far, it's kind of a unique sport in the rotational demands. It's also pretty unique in the length of the season, the overall volume. I mean, you look at some of these pitchers, they might be throwing 90 to 100 pitches a game. It's a long season, and I think the demands of baseball are certainly, uniquely challenging as a result. So when we get into the strengthening, correct me if I'm wrong, but before we get into all the really cool, sexy, Instagram-worthy exercises, I'd imagine we probably have to lay a pretty good base of physical preparation down, or like a foundation of strength, so to speak, before we get into the cool stuff.
Yeah, absolutely. And I think, I mentioned this previously on your last episode, is I'm not a big like social media guy anyway, so I don't really have like a social media presence. So I can only kind of argue the fact of like what you just mentioned, like remains to be true. It's the really like simple, easy little things that we do on a daily basis with consistency that probably make a bigger impact than that one time we did something really cool and everybody had fun and was like, oh, what is that? What are you doing there? And that had, like a really one time specific like goal for that athlete. So like it all kind of goes back to like, what is your baseline like arm care routine and program look like, and what are the things that you really prioritize with that, and rotator cuff strength, like elbow flexion extension strength, grip strength, and like forearm strength are the biggest kind of things that we look at in from like an upper body perspective, and we could like get into the weeds of like how you do that, but like that baseline, like these are the things that every baseball player needs to work on, end up being the exact same, right?
Right. Yeah, definitely. And it's one of those things, at the pro level or even the college level, a lot of times you get some good baseline testing data on some of these athletes, right? When they come in, you can do a variety of tests and assessment and strength measures and have all that documented. So if something like this happens, you know what that baseline looks like. Now, say you're someone like me who's, stuck in the private sector and, we get that, high school baseball kid in for that long-term rehab, shoulder, elbow, and we find ourselves in that mid stage of rehab here. How do we go about approaching that when we might not have that same, baseline data, or we might not even have any kind of familiarity with an arm care program at the high school level,
Yeah, and I would probably guess that high school kid probably doesn't have an idea of what an arm care program is outside of what he's seen on Instagram anyways. I think it's really just like the basics of like what like motions and what muscles a baseball player uses. So like you said, like the non like flashy things are like internal rotation, external rotation, and doing that like literally over and over again in a bunch of different ways that tricks them into thinking that they're doing something different is kind of how I think about it. And then obviously outside of just like your rotator cuff strengthening, you have to have some kind of like scapular like stabilization strengthening going on as well to incorporate like mid and low trap. And then like I mentioned before, some sort of like grip forearm strengthening involved in that as well. So trying to identify those things specifically in terms of like arm care is huge. And I know we're getting a little bit more into the weeds of that, but like as we mentioned earlier, and I'm sure we'll get to this at some point, of like like hips, ankles, thoracic rotation, cervical rotation, all those things kind of matter as well. So like those are things you can pepper in based on your athlete. But if you're just talking about like a baseline, like, hey, these are the most important things, or like the high points that hopefully every high school player should adapt to, doing some internal rotation and some external rotation kind of over and over again until their eyes bleed from doing it.
Right. No, exactly. And you mentioned before about variety of those things too, right? And so I hear that and I think, well, it's probably not just laying on the side with the, pink dumbbell doing this all day long. It's like, yeah, we're going to do some of that, but we're also going to do some band. We're going to do some isos, some eccentrics, some regular, just rep it out. And we're probably going to start down low by the side. And over time, I'm probably going to progress them up overhead. I like to do a lot of work from like an uppercut position myself, and then work it back into like what I call a 90-90, where the arm is like about 90 degrees abducted and at like 90 degrees external rotation, just to try and start getting into more of those like overhead type positions. But I think it's important, as we've been talking about establishing the baseline and foundation here, I think you need to have some kind of progression for whatever kind of strengthening you're going to do at first. And I think that's a common mistake I see in a lot of rehabs, is they get thrown decent exercises to start, probably similar ones to what I would start with, but there's no progression afterwards, right? Like, if I take an ACL, I'm not going to do straight leg raises for 5 months after an ACL. Just like I'm not going to do sideline band external rotation for 6 months after a cuff injury or a labrum injury. So I think that, building a progression of like, this is the phase 1, but this is the phase 20, but it's still general cuff strengthening. I think that's an essential piece in the strengthening, like phase 3 rehab type of world.
Yeah, I would absolutely agree. And I think that's a good like parallel of like, you're doing a straight leg raise, but like, what are you doing that straight leg raise for? And then how do you take that, like one step further and then one step further and then one step further? And I think sometimes we get lost in terms of like, hey, we need to totally change what the exercise is or what they're doing. And unfortunately, like we mentioned, like baseball is one thing over and over and over again. So like, instead of necessarily changing the exact thing that they're doing, like you don't have to change the internal rotation and the external rotation. You can modify, like other variables to make it more difficult or more just like sport specific, like you mentioned, right? So like, you can obviously change the position in which you're doing that, but modifying like how hard that is for them, the intensity of that, like the modem with which they do that, the tempo that they do that at, like all those like basic strength and conditioning principles, like applying that exact same thing to get your goal of like, what do I want to accomplish in these next, like 2 to 3 weeks of this like acute like microcycle, and how do I then change that and make that a little bit more specific to the goal that they're approaching of throwing, or if they're already throwing, of continuing to build cuff strength, if that's their primary goal or something along those lines.
Definitely, I love that. And even taking that concept and going a step further, I've had a few guys I'll do this for, where instead of holding the band or a handle in their hand, I actually take a ankle cuff and I strap it around their wrist, and then I give them a baseball to hold in their hand, and I'll let them grip it however they want to. If they're pitchers, usually they'll grip it in different pitch positions. But that way, at least we're just holding, the object that we're going to be throwing instead of just a handle. And it probably does nothing. I don't have any research to cite on this. But it's one of those things I've kind of picked up along the way, and I was like, yeah, I kind of like doing this. And people seem to like the athletes tend to like doing that as well, instead of just holding the band.
I mean, it's making it, that's, in all honesty, that's a progression, right? Like the athlete feels like they're doing more, which is probably the most important thing. It makes them like have a little bit more fun. I'm making some air quotes right now, but like they're at least having a little more fun than just doing a band. And then I think, even from what you're saying, like a step further from that, if you have like a CLX band or something, you could incorporate some form of like forearm specific strengthening with the pitch grip that they're using. Since if you think about like somebody throwing a splitter, their fingers are around the ball and their wrist action is going to be different than what they do when they throw a slider. So if you can put a ball in their hand, put a band around their arm, and use that in some sort of way to resist the motion that you want to get, like that's something that we've done as a part of like long-term rehabs, since I've been with the Phillies, and probably even since before that. But like, a guy talks about the first time he starts throwing his curveball, his forearm starts getting kind of sore. He's just not used to that like really hard ulnar deviation that he has to do on the ball. And then we're going to go back and be like, okay, how can we better reinforce this, or how can we better reincorporate this into their rehab process before they get to that point? That's exactly what you said, of putting a ball in their hand, putting a dowel rod in their hand sometimes, and putting them in that ball release position, or having them go through that range and practice what they're doing with their forearm. And I think, I mean, I feel like, like that's a big area of need that we can try to address for like long-term rehabs, and, like can be a result of why somebody gets hurt in the first place, because they start throwing a new pitch, and that's totally new stress and demands on their forearm and on their elbow that they're not used to. And what did they do to prepare for that outside of just throw the pitch? Nothing. So like, a low-hanging fruit would be to do that exact motion in some sort of strengthening way outside of just throwing it.
Right, and slowly progress back over time. It's revolutionary here. My goodness. When it comes to overall volume for these sort of things, Justin, if I think knee, like I've got guys that come in after ACL surgery, and our warm up, we're doing 150 straight leg raises, and we're doing 150 leg extensions, with weight just to try and bring that quad back. But when it comes to the shoulder, there's, I think, a little bit more of a balance that needs to come into play here. There's a lot more muscles involved. There's a lot more force couple action, and we want to get everything stronger, but we also don't want to like overpower things. Like, for example, I don't want to overpower an upper trap and start seeing some guy like shrug up every time he goes overhead. So when it comes to like volume for some of these different initial strength progressions, are you going like sets of 100? Are you going like 10 sets of 10? Are we still in the kind of 3 sets of 10 for everything lane, or where's the balance for volume initially in your eyes?
Yeah, so I think that kind of goes back to like what we had talked about in terms of like laying a base. So like, sure, when you start laying a base, like 3 sets of 10, 4 sets of 10, whatever you can do just to kind of get them used to doing things. And I think I kind of prioritize volume early on in the rehab process of like, hey, let's do a lot, like you mentioned, so that you're prepared to be able to do more later. And then like I said, you've got to kind of identify, hey, what's this like 4-week cycle look like, and what are my goals for this specific part of your rehab? And if it's as you're getting closer to throwing, we're probably, like tapering off a little bit and making it a little bit more targeted and specific to areas of need, and like trying to get the biggest like bang for our buck in that sense, and modifying it so that it's more so like less overall volume and less overall like exercises, and more targeted specific things to what you need. And then like it goes back a little bit to like what your goal is and what you're doing that exercise for. So like pre-throwing plows or using like med balls as a way to get ready to throw a baseball. I'm not going to have you do 3 sets of 10. That's just not realistic to work like a power or like really heavy rotational movement. I want you to work on the specifics of your mechanics and how you can translate that to that specific exercise. And then it's more so like 5 or 8 reps and less overall sets of that.
Right. So it comes back to what you're doing and why you're doing what you're doing it by the sounds. And, it sounds like, in general, there's a time to blow up the volume. If we're just doing base movements, like we're going to need to get really good at doing a lot of them. If we look at the extent of the season, like we talked about earlier, how long it is, how many throws guys are going to be making, that sort of thing. So I like the concept of hitting some volume early on. And then it almost sounds like, you were saying as we progress, but my mind actually went to like almost as like the motor learning, because I've recently been reminded that all PT is neuro PT to a certain extent. As the motor progressions or the neurologic demands of movement increase, that's when we start to kind of taper down the volume a little bit, because now we're getting into a more complicated movement pattern. It might be more difficult to kind of coordinate and put everything together. And I certainly think that's an area where initially I see a lot of people fatigue quick when we start doing those kind of patterns that they haven't done before. And it's one of those things, I don't want to be the one to reinforce, patterns that we don't necessarily want to see. I don't want to get into the weeds on compensatory patterns and different things like that. But going back to what I mentioned before about the upper trap shrug, like if you looked at a guy, how he used to throw before his injury, and you look at him now and he's shrugging his shoulder up every time, that's probably not a good sign. And we probably don't want to do things that would reinforce that.
Yeah, absolutely. And I think, especially at the professional level, like these guys are always trying to refine what they're doing and how they're doing it. So like one cue from you or from somebody else can make a major impact on how they're going to throw that day, and then how they're going to throw the next day, and how they're going to like take those things moving forwards. So you've got to be really selective with like how much and when you do things, so that they're not taking some of those like compensatory patterns, and that it's becoming another problem for you later on, or working against like the goal that you set at the beginning of your rehab program and the goal that everybody else has for them to accomplish. So you've got to be pretty selective with that.
Right, right. And ultimately, this requires a lot of attention to detail, which I know can be very difficult in the private practice for PTs. I see a lot of people in different states who, they're seeing 3, 4 patients an hour. And, I know I couldn't keep pace with that myself. It becomes very difficult to provide that individualized attention when you're seeing so many people all day long. But, I think that when it comes to settings like that, there's certain things like some of these new movements that you really have to make sure they hammer it with, really make sure they nail it, get the mechanics down, get the movement down. And there's other things like that side lying external rotation. Look, if they flare their elbow up 1 or 2 reps there, it's probably not going to be the end of the world. So let them do that when you're not looking, but when you're looking, make sure they hit the things that you really want honed in on, especially those mechanic type movements. And once we've established this base level of foundational strength, Justin, as we've talked about earlier, the progression is really key. And I think that's another area where PTs really struggle. And again, I'll kind of throw the stereotypical outpatient clinic out as an example. I don't see a whole lot of typical outpatient clinics with heavy dumbbells and barbells and racks and that sort of thing. I love when I see it, but it's kind of rare. When we have to start progressing someone beyond, the band strengthening and the open chain patterns and the cuff and the scap and all that, and we're ready to start doing some more heavy resisted, dumbbell work, barbell work, kettlebell work, whatever it is that way, is there anything that you like to go to as far as like an icebreaker to more advanced strengthening or stability interventions?
Yeah, I think from what you're mentioning, like you've got to make do with what you've got, and the benefit of what you've always got is you've got you yourself. So like manual resistance exercises are kind of huge, and you can be pretty creative with that. Like it doesn't have to just be on a table with them, doing like a D2 pat, like they're throwing motion, right? So like it doesn't just have to be that. You can take that and apply that to like a split stance position or like a half kneeling position, and you can position yourself so that you can be the resistant to be able to, like provide and know how much resistance they're capable of giving and withstanding. So that would be my first go-to based on what you described, and kind of what we look to incorporate sometimes of like, hey, this is your really like heavier loading day and we want to progress this. Like I can get a better feel for where you're at if I can physically feel what you're doing with my hands, as opposed to like, well, you kind of like compensated or it looked a little strange with the way you did the exercise. I can actually feel what you're able to do in different ranges.
Definitely. I like that approach. And I think the manual resisted exercise is something that's highly underutilized, because if you get them in the right position, you can certainly provide a lot of resistance. And oh, by the way, you can very quickly vary the resistance you're giving depending on what position they're in. And as you mentioned, if they're not as strong in a certain position, you're going to feel that very quickly. So you can kind of change your intervention strategy based on what you're feeling during a loading exercise that way. So I'm a huge fan of that. When I also hear at MRE, I think a lot of people in their mind go to perturbations. And again, that's another thing that we see a lot online. We see people hitting the arm in different positions and all that sort of thing. And it's funny because I feel like a lot of people don't quite understand what the perturbation's doing. If you're going to use a perturbation with an athlete you're working with, like what is the whole purpose of a perturbation in shoulder stability? And, why would you be doing it in the first place, Justin?
Yeah, so I think it kind of goes back to like them being able to like quickly fire a muscle and like be able to activate it and have some sort of like quote unquote like neuromuscular control. So it's really, in my mind, for like loose, like lax guys that have a ton of motion, and you're trying to like help them be able to better own the ranges that they have and better be able to just like be them, right? Like if somebody's got 130 degrees of external rotation, the last 10 degrees, sometimes they've got absolutely no control of that range and can't even activate their external rotators in that range. So like you start out probably with some like isometrics in that range and then work into doing some sort of like a perturbation where you're having them have like some sort of a co-contraction with multiple muscles in that range in different positions, like we mentioned. So that's like really where I see that as like a benefit. I think obviously you have to be a little bit like mindful of what kind of perturbations you're given. Like if you're just over here slapping their arm or slapping it as hard as you can, like it goes back to the same thing that I've said of like what's your why and like what's your goal for that specific thing. And that's where I would want to be a little bit more selective in terms of like this is why we're doing a perturbation and what it's important for this specific athlete, as opposed to like everybody needs some sort of a perturbation. Obviously everybody doesn't need everything, but
I think that's a great breakdown. And I always kind of looked at them as kind of like you mentioned, it's almost like a rapid manual isometric in a certain position where you're going to randomly push them in a certain direction and hopefully they don't move that way. But it's a little unpredictable. And I think they have a place, kind of like you said, but it's one of those things. I think they're a little overutilized, in my opinion. I think a lot of times people just go crazy with them, and I think, like you said, there's a time and a place for it, but I think in general I do a lot less of them than most people do in the rehab world, and maybe that's a fault of my own. Maybe I should be doing more perturbation work with people from a manual standpoint. But I kind of rank it next to I won't say the name, but there's an oscillatory stability device that a lot of people would use through different patterns. And I kind of called it the shake weight of the shoulder, for lack of a better way to put it. I think it's a good tool, but I don't use it nearly as much as I see other people use it.
Yeah, I think again, it really just goes back to the why, right? Like it's got to be a specific, like you have to have an end goal in mind for everything that you do. So like if you're just doing it to do it or doing it so that you feel important or they feel like you're important because you're there helping them do something, like there's no real like benefit in my mind, at least.
Anything to get that extra unit of neuro re-ed though, Justin, right?
Yeah, I mean, I guess I haven't had to think about that in a minute, but
you were talking earlier too, as we were talking about the initial progressions, and you threw out a few different things like split stance position and so on that way. And I realized that those are positions that, you know, they don't really change much at the shoulder, but they change a lot of the rest of the body. And I think that's an essential piece to reloading the shoulder, especially for baseball. You know, we've talked about it a few times. It's so rotationally dominant that not all of that is coming from just the shoulder. And if you're restricted for any length of time, we kind of need to make sure you're good everywhere. So it sounds like what you mentioned before, the split squat and like a kneeling position were kind of your go-to for kind of hitting more of like a global strength and stability thing.
Yeah, I think the goal of those things are really like segues to the positions that they throw in, right? So like if you think of a throwing motion, you're doing a ton of things with your arms in layback as far back as it can be. So we do a ton of things there. At ball release, we do a ton of things there. So like we're trying to simulate the same positions that you end up being in as an athlete with our exercises and with our exercise prescription. And I think you can take, like, my mind is like, just standing, half kneeling is more supported than a split stance position because you're having to use your legs, and that's the most specific to what you're doing. And then, like you mentioned, in terms of like strengthening, for the most part, when I'm throwing a pitch, my elbow is in a mostly extended position, so I'm not like ripping down on my curveball with my elbow bent. So me doing elbow bent forearm strengthening maybe isn't as specific as me doing some sort of forearm or like ulnar deviation with my elbow extended and my shoulder in an overhead position.
Taking a step further too, along with that, I think in general that helps keep the focus on the sport at hand, which is baseball, because again, we're trying to make athletes better at real sports, not the best at exercising. So if I can put them in those positions and I can load them in a variety of different ways, that's going to carry over to our end goal a lot better than hey, we're going to stand in a rack and we're going to grab a barbell and we're going to overhead press, 5 sets of 10 like a bodybuilder. Like, I think that just changing some of those other position variables, like you mentioned, I think that really carries over far better to the sport specificity, even with the shoulder loading. I might be able to load someone more with a strict overhead press than a split squat overhead press, but that split squat position does a lot more to incorporate everything else than just a strict overhead press would.
Yeah, absolutely. And then I think the other piece of that too is like that translates more so to those like performance goals that we talked about, and like can more easily be related to like, hey, you're trying to get more hip shoulder separation, and we can work on these exercises in this position, which is going to better prepare your nervous system and your motor control abilities to be able to do that when you're moving your body as fast as you can to throw a fastball 98 miles an hour. So you can get a lot more buy-in from players. And if you can, like relate that to what they're doing specifically, and with coaching staff and like position player staff and all the people that have their hands in the pots of these, like young athletes to professional athletes, like the better off you're going to be and the better impact that you're going to be able to make on that athlete and on that athlete's, like overall health and performance.
That's a huge piece right there, I think, Justin. And it's not just at the professional level, but even at your outpatient levels too. If you can show people that what you're doing provides value beyond what they're there for, which is to get back to their sport, and will help them improve and get better at it, I think that's a huge piece. I think it's also huge to incorporate other people in the rehab process here. And this is something we talk about quite often on the podcast. I feel like at the end of the day, I don't know everything. And when it comes to getting someone back to throwing a baseball, me, who's never thrown a baseball 100 miles an hour and probably never will, probably doesn't know nearly as much about it as the pitching coach, the athlete themselves, and so on that way. So I think getting to the point where you can incorporate, them in the rehab process is essential. And I think that this mid to late stage of rehab, especially from a strength standpoint, is a great spot to look at it. Look to do that with, because your pitching coach might say, hey, look, I was looking at him before and he was having issues with X, Y, and Z. Like, bring those into your rehab. Because I'll be honest, I might miss one or two of those if I look at your pitching motion compared to someone who literally does that all day long for a living. So it's one of those things. I think it's a great time and spot to kind of tap out and admit what we don't know and learn from those who know that well. And then I think we can provide things that will benefit and value them in return.
Absolutely. I mean, I think any of my colleagues and any of the players that I've worked with who have seen me throw a baseball have made fun of my said throwing of a baseball. So I'm not going to be the person that's really going to like fix or like delve into your mechanics, and two, like you're not going to believe what I'm saying as much as you're going to believe what your pitching coach who pitched in the big leagues or pitched at the professional level or pitched, even at a collegiate level, wherever you are, like those are the people that are going to get the most buy-in from your athletes. And if you can, like pass the baton a little bit to like include them more and highlight their knowledge in those stages. And like I said, even from the beginning, if I was in an outpatient clinic and somebody came to me, I would want to get all the information that I could. And like the pitching coach is probably, like going to teach me. And I, like my early, all stages of rehab, like if I can incorporate them from an early standpoint, and I can, like, I've been lucky to have been surrounded by and like learned from all those people around me and all the people in, like the Phillies org, like those are the things that I feel like I've learned the most, and like still have no idea what I'm looking at when these guys are looking at and breaking down deliveries and mechanics and all that. So really huge piece of the entire, like rehab process. And probably in my mind, I think that the most important piece, and sometimes those like pitching coaches don't recognize how much like impact they can have on what we do.
I feel like the biggest thing too that the the pitching coaches will tell you, at least in my experience, is, they might look at your program and might say, okay, well, a lot of strengthening, a lot of strengthening, a lot of strengthening. But you do realize he has to throw the ball at some point. And you mentioned before about pre-plyos and upper body plyos. And, I think, when everyone hears the term plyo, I think almost everyone mentally jumps to jumping or hopping or something like that. We don't always jump to throwing as a plyo, but it is a upper body plyo, right? We're going to release something, so force production. It might rebound back at us and we catch it, so force absorption. And I feel like that's another area that I see a lot of PTs struggle with. And I feel like there's certain progressions that I like and certain ones I don't. But before we get into that, what are your kind of thoughts and how do you kind of go about progressing, like, a return to plyo for upper quarter type of thing here?
Yeah. So, like you mentioned, it's kind of a step-by-step process that starts with like that good base. So like you're changing the intensity and the tempo really for me. So like if you're just moving a band really slow, whatever, doing the reps, that's your goal is like strengthening or just building volume, right? Like you moving that band faster in a functional position is more stimulating of throwing. So like as you move along the stages of rehab, you should be transitioning your focus to them throwing an object. And that can start with, like a cable column exercise or even a weight exercise before you get to doing some sort of plyo. And then it's the same principle of like what's going to stress their injury the least, but still stress it enough to get you better and keep moving that needle a little bit further. So like typically that's going to be like a two-handed plyo first and then a one-handed plyo after that. Since you throw a ball with one hand versus like two hands, you have the support of your other hand to take a little bit of stress off of your throwing arm.
Right. I like that. I like that progression, two hand to one hand. I like to progress the weight of the ball over time. And no, I don't just mean like the little weighted balls that weigh like 5 ounces. Sometimes I have people throw like med balls, and we'll work it up pretty heavy. We'll go to the 12, the 14, the 16. It's one of those things where I've found, there's conflicting research on a lot of things, but I've found a lot of athletes mentally feel more confident when they know they've thrown the 16-pound ball with that arm and the baseball weighs less than a pound. So it's one of those things, if nothing else, I suggest progressing up to some of the higher load things over time when they demonstrate the ability to do so, just to kind of help them from a mental side, because coming back from some of these injuries can be mentally difficult. And if you can show them, hey, you can throw a 16-pound ball, then again, the little baseball might feel easy in comparison. The other thing I found is when we get past the initial plyo and into the mid-tier plyo, it is perfectly okay to incorporate some body weight force production, force absorption. You can do a lot out of a push-up position. I've also done a lot of different things from like incorporating dumbbell drops and catches, which I feel like a lot of people talk about lifting weights. They don't talk about dropping and catching weights. But that's a very good way to get like a quick change in the velocity of the arm, and you can change the position of that as you see fit. I've also become a huge fan of those jammer arms. We don't have any in the clinic, unfortunately, but I like the concept of having something that I can literally start standing one direction and turn and rotate and explode the other direction and kind of punch through as like a very fast, like rotation, a more rotational focused plyo, I'll say, because we don't want our plyos to just be all one directional. We kind of have to incorporate everything, kind of like we talked about before.
Yeah, absolutely. And to your point, even if you don't have a jammer thing, like if you've got a barbell, you can set up a landmine in like a corner of a room to that extent. So like landmine things can be huge with that as well. And I think it all goes, sorry to sound like a broken record, but like the why do pitchers throw a baseball, or what's like the primary like system that they're using, and it's power production. So the more that you can incorporate those things into your plows and into your progression after you feel comfortable with them, just like moving their arm in that position, the better your progression is going to be and the better prepared they're going to be to throw. And then I would say at this point, any like credible baseball program is going to have some sort of like med ball like performance program that they do as a part of like their normal routine. So there's a ton of like mechanical and like delivery things that can be worked on with the medicine ball. So like if you can incorporate those things into your plyo program, like it's only going to be that much better, and the end results of your rehab process is only going to be that much better.
I agree. It's one of those things I found, like, if you're working with baseball athletes, I feel like the medicine ball is the essential tool to have. We talked about that with Joey Greeny back on the podcast a couple months ago as well. And, he said that's his primary tool for developing rotational power is it's just a med ball.
Right.
It's nothing too fancy or elaborate, but if it gets the job done, then roll with that over the $2,000 or $20,000 fancy piece of equipment. Sometimes less is more, I find, when it comes to the equipment piece of this phase of rehab.
Yeah, absolutely. And then like even we can backtrack from that, like when you're throwing a med ball, something's leaving your arms, you kind of have to use your arms to use that. But like back up from that, and you could take a band, or like if you have a 3D strap, obviously that's ideal, but you can take a band and wrap it around you and work on hip shoulder separation, work on that while somebody's not able to use their arm. So like take that across the spectrum, and that can be your progression, right? Like you did things with just your lower body and just your trunk. Now you're incorporating your arm into that, and then a projectile is actually leaving your arm as you're doing that forcefully. Like that's a pretty sound progression in my mind, at least.
Yeah, no, definitely. And I think I alluded to the mental side of rehab a second ago, and I think that's something that helps tremendously on the mental side of rehab, because you can get guys doing that stuff very early on in the process. You don't have to wait until month 6 to start doing lower body stuff after an upper quarter injury. You can find ways to adjust and modify and so on that way. So I think that's a very essential piece to kind of give people a feeling of control back, a feeling of normalcy back, instead of just, continuing to do more of this over and over and over again. Not that this isn't great. It just, sometimes this gets boring.
Right, exactly. And that's like, I mean, the biggest piece of most of this is like athlete and patient, like engagement and feeling of getting better, and they have some sort of route. So the more you can, give them that from the beginning and create an environment where they feel like they're not only just like working on making their arm not hurt, but working on being a better baseball athlete in the time where they can't be a baseball athlete, like better they're going to feel about it, and the better you're going to feel about the job that you do over the course of whatever time you have with them.
Right. At the end of the day, you're treating and working with the person, not just the diagnosis that they're there for. So
Absolutely.
Justin, I feel like we've covered a lot of ground here into the strengthening and plyometric phases of shoulder and upper quarter type of injuries there. Do you have any kind of closing thoughts or closing remarks or anything we might have missed as we were talking today?
Man, I feel like we could probably keep going all night if we really wanted to at this point. But I think I'll just lean on, that last point that we made of like, we're treating people, and even at a professional level, like these people are just people like everybody else. So the more that we can make them know and feel that we really care about them as people, and like make an impact and provide some sort of a route of like, hey, this is where we're going to go, and it's not going to go the way that you want it to, and it's not going to go the way you expect it to, and there's going to be a ton of challenges on the way, and the better you can accept that process, like the better you're going to come out on the end of that. And if you can make it through all these challenges and difficulties, like you can take on anything, and throwing a baseball sometimes becomes really easy when you can't even straighten your arm. So being able to get through that is like a pretty rewarding process. And the more we can highlight that process and the opportunity that being hurt like presents to improve your performance and improve as a person, like the better job we're doing, in my mind, I think.
Definitely. I completely agree with that. And I can't echo that point more. Earlier I threw a little shade on the social media side for exercises and that sort of thing. But I say quite often that I think my iPhone is the most powerful tool that I have from a PT standpoint. And what I mean by that is we can take pictures and videos of someone pretty easily. And sometimes people get a little discouraged during their rehab because it's not always the easiest road. And we can kind of flip back and say, hey, remember 2 weeks ago when you couldn't even fully straighten your arm? Now you have full extension. So sometimes it kind of helps to give a little visual reminder to people too that, yes, it's a long road. Yes, it's a process and it takes time, but, just kind of quick little reminder to yourself of where you were not that long ago and where you are now. It's not always a marathon of ups, but sometimes it's nice to have that little reminder that not that long ago you're in a little bit more of a valley and now you're closing in on a peak.
Absolutely. One of our pitching coaches uses the phrase, just get like 1% better every day is kind of what we live by. So
Justin, I feel like you mentioned before, you're not a big social media guy, but if people wanted to reach out to you and find you online, actually, you're more the Sony Walkman generation. Never mind.
Yeah, I do have like a LinkedIn profile, so you can reach out there. And then, like you can always post my email on your podcast, and they can reach out to me there as well.
Awesome. Yeah, we will link to all of that below. So if you want to reach out to Justin and get in contact with him, you can do so there. Justin, it's always a pleasure talking with you, man. Thanks for your time.
Absolutely. Appreciate you.